Welcome back to my channel. Today we are going to learn about two important periodontal procedures, gingivectomy and gingivoplasty. These are very common surgical procedures which are used to reshape or remove the gum tissue to make it healthy and aesthetic. So let's begin in simple language. Of gingivectomy means it is the excision of the soft tissue wall of the pocket, and it is done by removing the pocket valve. It provides visibility and accessibility for complete calculus and plaque removal. So it means surgical removal of diseased gum tissue or gingiva, and it is usually done to remove the pocket and large gums or fibrous tissue. While gingivoplasty, it is the recontouring of gingiva that has lost its physiological form rather than elimination of pocket. It means reshaping of gingiva to get a normal physiological contour. It is basically to make a gum look natural and healthy again after disease or surgery. So purpose indications while gingivectomy is indicated. So it is indicated when to eliminate supraalveolar pockets and the abscesses. It is helping removing the fibrous or edematous enlargement of the gingiva. It transfer roll or blunt margins to physiological form, that is a knife edge. Create more aesthetic form in cases in which exposure of the anatomic crown has not fully occurred. It creates bilateral symmetry where the gingival margin of the one incisor has receded somewhat more than that of the adjacent incisor. It is indicated when exposed at additional clinical crown to gain added retention for restoration procedure which is assist to subgingival area. So contraindication when do not perform gingivectomy in the presence of the thick alveolar ridges and interdental craters, when infrabony pockets are present, in which because bone is involved. If pocket extend till and below the mucogingival junction, inadequate oral hygiene maintained by the patient, in uncooperative patient and in medically compromised patient. Procedure of the gingivectomy is surgical. So, in step 1, the pocket on the each surface are explored with a periodontal probe and it is marked with a pocket marker. Insert the probing weave to the bottom of the pocket and mark the depth with the puncturing peak. So, in diagram you see this one is a probing bow peak which is inserted to the bottom of the pocket. This one is bottom of the pocket. And this one is on the other side is a puncturing peak which will mark the depth of the pocket. This is point marker. So in step 2, periodontal knives are used for the incision on the facial and the lingual surface as auxiliary instrument. Bart Parker blade number 11 and 12 and scissors are then used. So the incision is started apically to the point. So this one is point. So just apically to the point, an incision is started, making the course of the pocket, and it is directly coronally to a point. This one is point between the base of the pocket and the crust of the bone. So the incision is started apically to a point marking the course of the pocket, and it is directly coronal to a point between the base of the pocket and the crust of the bone. Discontinuous or continuous incision may be used. The incision should be bevel at approximately 45 degrees to the tooth surface, and it should recreate as far as possible the normal festoon pattern of gingiva. In step 3, remove the excised pocket wall, clean the area and closely examine the root surface of any deposit. Carefully curate out the granulation tissue and remove any calculus and necrotic cementum so as to clean and smooth the root surface. In step 4, cover the area with a surgical pack. Healing. Basic healing is done by a secondary intention. The initial response is the formation of a protective surface clot. Then the clot is then replaced by a granulation tissue. Within the 24 hours, there is increase in new connecting tissue, mainly the angioblasts, and by the third day, numerous fibroblasts are located in this area. The highly vascular granulation tissues grow coronally, created a new free margin, gingival, and sulcus. So capillaries derive from the blood vessels of the periodontal ligament, migrate into the granulation tissue, and within the 2 weeks they connect with the gingival tissue. So surface epithelialization is generally complete after 5 to 14 days. Initially, keratinization is less than what is prior to the surface. So complete epithelializations take place about 1 month, and 10 to 13 days connecting tissue healing take place. So thank you for watching. Please like and share and subscribe my channel, and see you in the next video.